Good afternoon, everyone. My name is Sema Sgaier, and I am co-founder and CEO of Surgo Ventures. We are a not-for-profit dedicating to solving health and social problems with precision. So the theme for today's discussion is, how do we close the racial maternal health gap in the US with better data? I am so thrilled to see that we have close to 300 participants joining us today. Welcome to all of you. And I'm deeply honored with such an incredible group of maternal health experts with me here today. They will be sharing their views on how we can combine better local data with smarter policies and solutions to address the devastating maternal mortality in the US, especially for women of color. But before I introduce our panelists, I have a message to share from a very special guest who sends her regards. US Representative Lauren Underwood, the co-founder and co-chair of the Congressional Black Maternal Health Caucus.
Hi, everybody. I'm Congresswoman Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. I would like to begin by congratulating the Surgo Ventures team on the launch of your new Maternal Vulnerability Index. The tool you're unveiling today can help to shed light on some of the most pressing questions our nation is confronting. Why are pregnant people dying at higher rates in the United States than in any other high-income country? Why are there such significant racial and ethnic disparities in maternal health outcomes? And what can we do about it? Without data to pinpoint the clinical and non-clinical drivers of maternal mortality, morbidity, and disparities, we cannot implement and scale evidence-based interventions to save lives and promote equity. As the co-founder and co-chair of the Black Maternal Health Caucus, I have been committed to comprehensively addressing our nation's maternal health crisis, including through my Black Maternal Health Momnibus Act. The Momnibus is a suite of 12 bills that includes investments to support community-based organizations, grow and diversify the perinatal workforce, and address social determinants of health like housing, nutrition, and environmental conditions. I was thrilled to see these critical investments included in the Build Back Better Act legislation advanced in the House of Representatives. And I look forward to working with my colleagues in the House, Senate, and White House to get this legislation across the finish line. I look forward to working with all of you on this urgent mission as well. Congratulations again on the launch of the Maternal Vulnerability Index, and thank you for the opportunity to join you for today's exciting event. I look forward to the day that we're back together again in person, but until then, take good care of yourselves.
We're so grateful to Representative Underwood for her words of support. In her message, she mentioned the Maternal Vulnerability Index, or MVI for short, which is an important context for our conversation today. We all know that maternal mortality and the maternal mortality crisis in the US is complex. The risk of dying can change from state to state, from county to county. We also see outcomes, as she mentioned, worse for Black and American Indian, Alaska, and Native women. So if we want to shift this trajectory and close this racial gap, we first need to understand why it's happening. And we need to look carefully not only at the personal and clinical, but also at the environmental context in which women live. And until now, there has been no standardized, comprehensive, and granular way to view maternal health in a holistic way using data. This is why we are thrilled to unveil this index today. The MVI is the first county-level, national-scale, open-source tool to identify not only where mothers are dying, but more importantly, why are they dying and why are they having worse outcomes due to pregnancy. We are very grateful for the support that we received from the Bill and Melinda Gates Foundation to make this work possible. So now going back to the index and the data, even with the level of data that we have today, the question still remains. How can we use better data to craft smarter policies and solutions to improve and save the lives of mothers and babies? And this is exactly why we're here today with our panelists to really talk about solutions. So before we get into the exciting part of our discussion today, which is the panelists, I do want to note that we will open up questions from our audience in the final portion of our conversation today. Please post your question via the Q&A function. The chat will not be accessible. There's a Q&A function, and we'll do our best to answer all of them. So first, I would like to introduce our panelist, Christy Turlington Burns. Before founding Every Mother Counts, Christy received international acclaim as a model representing the world's biggest fashion and beauty brands. Her work in maternal health began after experiencing a childbirth-related complication in 2003. Under Christy's leadership, Every Mother Counts has invested nearly $21 million in programs in Africa, Latin America, South Asia, and the United States, all of which have been focused on making pregnancy and childbirth safe for every mother everywhere. Christy, it's such an honor to have you here today. So to begin, I'd love to hear if you can tell us what brought you to this work and how your personal experience actually spurred you to become such an incredible maternal health champion, both in the US as well as globally.
Thank you so much. It's so nice to be with you all here today, talking about this important topic. I became a global maternal health advocate the day I became a mother, which was back in 2003. But of course, it took me some time to figure out exactly how the experience of giving birth and the postpartum complication I endured after that birth would impact my life and put me on the path that I'm on today here as the founder of Every Mother Counts. I was sort of shocked and outraged really to learn the statistics after I became a mother. Maternal mortality at the time was estimated at 500,000 plus women per year and girls per year dying each year. And those numbers really had not budged in decades. And to learn that information after becoming a mother was certainly too late in my mind. So I've really made it my mission to educate others, everyday citizens, and whoever will listen to me about the statistics globally and here domestically. At the time that I became a mother, the United States was ranked 41st in the world, and today we are ranked 55th. So we have continued to fall behind quite rapidly, and that's sort of in contrast to most of the world, as some estimates have come down and some of the figures have improved. The United States actually is one of only 2 industrialized countries with a rising maternal mortality rate. So this information and experience led me to create a film called No Woman, No Cry, which came out in 2010 and initially was a campaign, again, just to raise awareness for people to understand the challenges and also the solutions that mothers face in their respective countries. And then that became an organization, a grant-giving organization, advocacy campaign and mobilization entity back in 2012. We've continued to be storytellers. We've made about 30 films or so at this point, looking at those challenges and solutions around the world at the local level and at the sort of broader national and global level as well. So I'm very passionate about this work. I've seen some and participated in some of the momentum that has been built, and yet there's so much work to be done, and which is why I'm so delighted to be with you all who are really paving the way to continue sustainable change in maternal health.
Thank you, Christy, for sharing that. And we're going to talk more about the power of personal stories and how to combine that with data in a bit. Our next panelist is Dr. Lola Okito. Dr. Okito is an attending physician right here in our capital and Children's National Hospital Division of Neonatology and an affiliate faculty member of the Child Health Advocacy Institute. Her clinical research and advocacy interests include the psychosocial and socioeconomic factors that impact neonatal health outcomes. Lola, welcome. It's so wonderful to have you. So Lola, when we looked at our MVI and all the data that we were able to put together, it shows that Black and Indigenous women are more likely to live in what we call high vulnerability areas. These are areas that have a lot of factors which make women there more vulnerable. And this is, in our opinion, a sign of structural racism. We also know that common sociodemographic factors such as education and income actually do not protect Black women from being subject to worse maternal health outcomes than white women, which is another sign perhaps of pervasive racism. I'm really curious to hear from you as a clinician. How do you see racism manifesting in the lives of your patients?
Thank you. That's a great question. I first wanted to say thank you for having me here. It's a true honor to be amongst this intelligent and such well-accomplished panel of speakers. You asked a very interesting question. You know, undoubtedly as a clinician, I believe that the manifestations of racism have already impacted my patients long before I meet them. You know, the downstream effects of structural racism includes the racial health inequities that we see in the medical setting. In terms of definitions, when I say structural racism, I'm referring to the totality of ways in which society fosters racial discrimination through mutually reinforcing systems. These systems include housing, education, employment, earnings, and so forth. You know, all of these systems, all of these institutions really influence our social determinants of health, which has been defined as those conditions in which people are born, grow, work, live, and age. So when taking a bird's eye view of the racial health inequities that exist in the United States, there's no doubt that structural racism is at the root. I think additionally, I'd like to mention that the role of personally mediated racism in medicine is also a form of racism that exists. This is often what people think about when they hear the word racism. It includes prejudice and discrimination, where one has differential assumptions or actions towards others according to their race. It includes explicit and implicit bias. And when it comes to racial health inequities, I think it's important for clinicians like myself to pay a very close attention to the role of implicit bias specifically as it relates to the care that we provide. Implicit bias is this idea that we act or do things based on our own stereotypes without even consciously being aware that we're doing so. For example, studies have shown that Black children are less likely to receive adequate pain medication after surgery or in the emergency department. And as physicians, we don't want to hear that. We don't want to hear that we're giving differential treatments to patients based on race, but it happens. Implicit bias is real and it affects the care that we provide. So I think in addition to structural racism, also forms of personally mediated racism, such as implicit bias, is so important for us to recognize, specifically as a clinician. And we have some work to do on our own to really determine how the care that we're providing, one patient at a time, contributes to the racial inequities that exist here in this country.
Thank you very much, Lola. I think you just laid it out so well. It starts even before the women show up in the clinic,
right.
And then also in the clinic. So it is a pretty complex issue that has many layers that need to be unpacked. Our third panelist is Dr. Marianne Etiebet. Dr. Etiebet is the lead of Merck for Mothers, Merck's $500 million global health initiative to create a world where no woman has to die while giving life. Since 2011, Merck for Mother programs and partnerships have resulted in healthy pregnancies and safe deliveries for over 13 million women in 48 global sites. Incredible scale. Marianne, welcome. At Merck for Mothers, you collaborate across sectors to ensure that what you aptly call the mom effect. And I love that concept. Can you please explain it to our audience and why you believe it is so important?
Sure. Thank you, Sema, and thank you so much for inviting me to this conversation. I can't wait, to get into it. When we talk about the mom effect at Merck for Mothers, we're really talking about how when you lose a mother, it has ripple effects, not just on the family, but on communities and societies. We know that when a mother lives, her infant is 15 times more likely to survive. Her children are 10 times more likely to complete their education. Women and their families and their children are contributing to communities and to the economy. All of that is so essential. And so an investment in maternal health is really a down payment, on all of our futures. And one of the things that has always struck me about maternal health is about how it's not just a vital sign, of our health system. It's a vital sign of society. And I'm so excited that today, with the release of the Maternal Vulnerability Index, we actually have a vital sign that we can use, to measure mother, maternal health, and the broader impacts and what it tells us more broadly about society, as Lola just aptly talked about, the systemic and structural racism that is really driving these inequities and disparities that we're seeing in maternal health outcomes.
Thank you, Marianne. And I also loved how you said an investment in maternal health is down payment on the future. And perhaps that's a great slogan to go with to some of our policymakers. And, just how important maternal health is in general for everyone and for the future of society. Thank you. And the final panelist joining us today, so excited, is Michele Blackwell. Welcome, Michele. Michele is a public policy manager for Uber Technologies, Inc. In this role, she works with states and cities in the Mid-Atlantic region to advocate for innovative transportation policies, discuss modern approaches to working in the gig economy, and develop critical relationships with community-based organizations. Very exciting to hear Michele recently worked to provide free rides to vaccine sites for vulnerable residents, essential workers, restaurant workers across the District of Columbia, Maryland, and Virginia. Such an important initiative, Michele. Thank you. Michele, we all know, and as we already mentioned, clinical care is important, but we also know the structural, environmental, and community level factors are just as important. And one such factor is actually access to transportation, captured actually also in our MVI. Through the Rides for Moms program, Uber is providing free rides to prenatal care appointments for moms in the DC area, and leveraging the Uber health platforms to also provide logistic and management support for these rides. I'd love to hear from you about this program, Michele.
Well, thank you, Sema, first and foremost, for having me here. This is such an important issue, and congratulations to Surgo on the launch of the Maternal Vulnerability Index and the MVI. Black mothers in particular living in the District of Columbia are facing terrifying numbers when it's time to give birth. As of 2019, the maternal mortality rate in the district was 35.6 per 100,000 live births, and that's across the board. And that was compared with a national average of 29.6 per 100,000. The rate for Black mothers is so much higher, at about 71 deaths per 100,000 deaths. And according to the CDC, when it looked at this issue, pregnancy-related deaths were associated with several contributing factors, including access to appropriate and high-quality care, missed or delayed diagnosis, and a lack of knowledge among patients and providers around the warning signs during their pregnancies. And what was interesting about that study was that it suggested that about the majority of the deaths, about 60%, could have been prevented by addressing these factors at multiple levels. And so that's really what our partnership Rides for Mom is attempting to get at. We were so excited to partner with you, Surgo, and with 2 federally qualified health centers, Community of Hope and Mary Center, to provide free rides to 1,000 pregnant people to their maternal health appointments. And we're doing the rides in 2 ways. They can either use a voucher, which they can just, for those who have used the Uber app before, it's similar to a promo code, it's put in. And so whenever they need to go to their rides, they are good to their appointments, they can put that code in and they're able to go. But we recognize that there are some mothers who don't have access to smartphones, who may be unbanked. And so through our Uber Health tool, which is a dashboard, those community-based organizations that we're working with, Community of Hope and Mary Center, will schedule those rides for those mothers. And so what we're hoping through this partnership is to not only provide transportation to some of the most vulnerable living in Washington, D.C. and surrounding areas, we're also hoping to find out through an evaluation study, looking at the potential impacts of what closing that transportation gap can actually do in addressing the maternal health challenges. So we're hoping to share those results, as you know, Sema, next summer. And I'm hoping that this can help inform policymakers who are really seeking to address those health disparities.
Thank you, Michele. And what I really appreciated about this partnership is your flexibility in terms of, how those rides could be scheduled right from the app, outside of the app, through, phone calls, which was fantastic, taking into account the diversity of the women that we're working with and what they're able to do. Fantastic. So we're going to now be moving to our Q&A discussion. Apologies, not Q&A, joint panel discussion. So I'm going to be starting with Lola. Lola, Marianne actually, again, as I mentioned, talked about the investment or a down payment for the future. And you're a neonatologist and you work with babies and moms. Love to hear from you about how maternal health actually influences infant health and eventually health throughout the life course, and how you've seen this affect your patients.
Great question. Undoubtedly, maternal health directly influences infant health, from what mom eats to where she works to where she lives. All of this has very direct biological effects on the baby that's growing in her womb. Our hope is that the baby is born healthy, but sometimes babies are born critically ill or born too early. And these are my patients. That's the patient population that I take care of. Sometimes we can relate the infant's illness directly to a maternal health condition, such as hypertensive disease of pregnancy, but sometimes we can't. Our goal is to eventually discharge that baby home. And honestly, that's where the real work begins. Because once the baby is discharged from the hospital, they're then often exposed to the same social determinants of health that their mother is exposed to. And we know that the psychosocial environment that children grow up in influences not only their social emotional development, but it's also linked to their own physical health as it was to their mother. And thus, when they become adults, their health will influence the health of their children and so on. But this is why we as neonatologists are beginning to recognize and accept the responsibility to really follow through for our patients. And when I say follow through, I mean that really means more than just following up on our patients to see how they're doing afterwards. It means more like connecting our patients and families to the support services that they need as early as the NICU stay. We know that the medical care that we provide is just a small part of the big picture. Really connecting our patients and families to the support services that they need begins in the NICU, and it's really paramount for their overall health and the success of the family to help break the cycle of poor health outcomes, as it can happen generation to generation.
Yeah, thank you for that. I mean, we just cannot separate maternal health from infant health. It goes hand in hand, and it's a unit and beyond, actually, as you highlighted. So I'm going to move now to have a bit of a conversation around the data side of the issue, and I would like to start with Christy. And Christy, we know that the in-depth understanding of data and statistics and all of those numbers is really important for creating evidence, to inform policy. But your nonprofit, as you mentioned, focuses a lot on storytelling and on the power as a powerful way to drive change. Tell me about ways in which you've combined data, research, and storytelling to lead to improvements in maternal health.
Yeah, I mean, we really work to achieve quality, respectful, and equitable maternity care for all by giving grants, working with partners and thought leaders to increase awareness and mobilize communities to take action through the advocacy efforts that we take on. And one of the ways we do this most powerfully, I think, is the storytelling, which I spoke about earlier, and that it's sort of the origin story of this organization. I think by highlighting the stories of women, centering the stories of women and the voices of women in their communities, speaking their truth from their perspectives, as well as the providers who care for them. That has been one way to really elevate, the issue, but also really highlight the solutions. I believe that qualitative data and quantitative data are equally impactful, and I think that's one of the reasons why we've continued to make stories and create stories and follow those stories, because there's nothing more powerful than when you're in a room or in a conference or in a hospital setting where a woman's voice is really centered, and where her needs and her wishes and her feelings about how she's cared for are really taken to heart by those who are around her. So I can't underestimate the power of story more than the work that we do at Every Mother Counts.
Mm-hmm. Yeah.
And I would even add, Sema, that it's been those stories that have really fueled the momentum and raised awareness, for this issue. And the data such as yours has now, impelled us to act. There are two other dimensions of data I'd love to bring up, if that's okay. And that's the data around how well we're doing. And the data that holds us accountable. What we found with some of our collaborators and partners is there are challenges to connecting data around work that happens in the community or work that's happening, for example, in the hospital. And so we need to actually be able to figure out ways that data can follow people, as they go through their pregnancy journey, so that we can also use it to hold ourselves accountable.
Mm-hmm, mm-hmm. Yeah, that's such an important point, not just like how things are, but how are we doing in response to the current situation, and are we doing better or worse? Yeah, thank you, Marianne, for raising that. And to you, following up on that, we often think about how we use data to develop solutions and who's designing those solutions. Is it people from outside or people from inside? How do you think hyperlocal data can augment community engagement? Because we know that when the community is engaged in developing solutions, they're much more effective. And so how do you think that we could support them and augment that community engagement?
It's so important, Sema. And another point around that, there's this whole saying, we count what matters, and what matters we count, but it's also who counts, that matters. And we've seen that when we investigate deaths or we investigate near-death adverse events, who is doing that investigation actually influences what the outcome and the recommendations are. So when you have women with lived experiences, or when you have community voices participating in, for example, maternal mortality review committees, you actually see that they identify more events that could have been preventable than if it's just the kind of medical team or facility team that's doing the reviews. And this is not just an interesting finding, it's a life-saving finding, because the more issues or episodes or events that are identified as preventable, then the onus is on us to figure out what the intervention is to prevent the next death. And that's where the hyperlocal data comes in, because that is what is going to help us understand the specific conditions that, in each community that we need to, target, in order to prevent the next death.
Mm-hmm. And do you find it common to have mothers be part of these review committees? Is that a standard practice?
So, right now, I think it's becoming more of a norm. But I will say, and I think Christy mentioned this, there really has been an evolution in this space in the past 10 years. When Merck for Mothers started in 2011, actually one of our top priorities was to invest in data generation and evidence generation, because we didn't even know, the United States was not even reporting on a lot of this data. And excuse me. And as part of that, we supported the CDC in doing these state-level maternal mortality review committees and encourage the work to include patient voices, include community voices, and actually expand the remits to look not just at mortality, but at morbidity. Because for every death, we're seeing at least 100 times more near-death adverse event episodes, and that can tell us a lot about what we need to do to prevent the next step. What I will say about your question around patient voices or community voices is that needs to be the norm. That needs to be the standard. We cannot be doing this work without not just people with lived experiences being part of creating the solutions, but actually leading on the solutions. And that links back to your point about hyperlocal data, because the people who are going to lead on solutions based on hyperlocal data need to be local leaders.
Mm-hmm. Yeah, that makes a lot of sense. And so, when we have data, sometimes good, sometimes not so great, but there's always some data. And so, Michele, a question to you, as a public policy manager, what data do you see being most critical to crafting policy to support maternal health?
I feel like, I'm probably just reiterating all the great points that were mentioned earlier, but when I really think about this, honestly and truly, the best data comes from the mothers themselves. And what I mean by that is hearing them and their needs of what they need in terms of support so that they have a healthy and happy pregnancy. And so as Marianne and Christy were talking, I was thinking about there is a piece right now, our local NPR station, WAMU, and its online publication, DCS. And I'm saying this because I want everyone to check this out. They're doing like a multi-part series right now on maternal health disparities in Washington, D.C. And in particular, they're talking to Black women and hearing some of their stories about how they have felt treated, during this very vulnerable time in their life is just breathtaking. And so one of the things that I'm hoping, at least through our partnership, is that we listen to them and hear what it is that they need and try to adjust. So for example, when we were talking to some of the participants in this program, cost and unreliability of public transportation those are the most common reasons why those women feel it's difficult to attend their prenatal care appointments. This is 68% of our participants have said this, right? So that means it's incumbent upon our lawmakers to then try to help address that issue by meeting their transportation needs. So going back to the point of hearing what mothers need and then trying to adjust based off of that. And I think developing data tools that sort of focus on what it is that they need and then providing those recommendations is where we need to go. There's been a lot of academic work recently in this space, which is great. But I think it's most beneficial when we hear directly from the women who are actually losing their lives on this.
Mm-hmm. Yeah. I completely agree. I mean, academic work is very powerful. It provides evidence, but the voices and also empowering these women with data themselves that others are collecting in a way that's tangible and they can use to do advocacy directly, I think is also very critical, as well as hearing what they have to say, both in terms of the problem as well as the solution. So just moving on the same topic, Lola, as a clinician, what are the top pieces of information or data that you currently don't have access to that you wish you had access to help you guide in providing better clinical care?
Yeah, this is a great question. I think as it relates to health equity, I think there's a lot that remains unknown. We can't, when we look at, as you mentioned earlier, Sema, we were looking at the MVI data really showed us that, if you control for education, for example, Black women still remain at higher risk. But, it can be so difficult to tease out the contribution of systemic racism, for example. How do we quantify that? How do we quantify it? So us as academics and, we're looking for numbers, we're looking for data to really follow this, but I think that we need to change our perspective when it comes to tackling some of these issues. And that includes changing our mindset that quantitative data is the true and only data. I think reiterating everything that everyone says here, qualitative data is equally important, and really figuring out how to use the narratives from our parents, from our patients, from our mothers, and figuring out how to turn that into interventions and really follow it is going to be key. So I think really us as academics and in the field that we are in, we need to elevate this and the qualitative studies that are evaluating and speaking to these mothers need to be in those high impact journals just as much as the quantitative data is as well.
Mm-hmm. Completely agree. We need to reach out to those journals and make sure that they're also publishing the qual narratives, which is, as all of you say, so important. And just kind of to wrap up this data section, Christy, I'm curious if you think there are any questions that you would like to have answered with better localized data that are really pressing.
I was just going to add, I guess, earlier that that importance of having the community folks in the room while creating these models and interventions and solutions is just so critical. we often are hearing from our community-based partners that when they do get invited to those tables in those rooms and do spend the time to share stories and share observations and experiences, that that data doesn't always come back around full circle to them in a meaningful way. And I think that's something that that there's a real demand for, and I think that will ultimately be the right path towards actually, you know, taking the data, whichever form it's in, and actually moving that to action. So yeah, that's just an observation that I've seen, and something that I'm really excited about this index for, is to have that level of localized data at the ready, and you know, that is attainable and accessible for all who could really benefit from it.
And we're actually excited about, you know, community engagement with this data to not only to use, but then to actually evolve and take it to the next level. I think that's going to be really, really important. So, you know, we all talked about the racial disparities. We talked about the different forms of racism. Lola, you highlighted implicit bias. Marianne, I'm curious to hear from you. What kinds of solutions do you see that are working in addressing unconscious bias or implicit bias, and which ones are working or not working in your opinion?
I think, as Lola mentioned, you know, there is work that we have to do in order to not just tease out, you know, those contributions, but to know what effect our interventions are having. And I will say that we are actually really at the beginning of our journey of understanding this, and we need to invest more in this area of work. Implicit bias training is not enough. I think we all understand that. But the question is, you know, is what actually does make the difference. You know, I think ultimately it comes down to valuing and respecting, you know, each human being as a human being, listening to them, as Michele said, responding to what you're hearing, acting on it, and meeting people where they are. But in terms of some of the solutions that our collaborators, especially in the Safer Childbirth Cities initiative, are advancing, you know, include work to tackle some of these underlying social determinants of health. You know, Michele, you mentioned, you know, support around, you know, transport. You know, a number of them, including in DC, are working on that. Also working on housing insecurity. So aiming to ensure that, you know, for example, pregnant people, you know, have access to shelters, and there are, you know, expedited processes, you know, for them. Childcare is another big one, you know, so identifying and, you know, supporting resources to provide childcare so people can actually go for medical or clinical visits. We talked about, you know, training, whether it's in implicit bias or trauma-informed care. But I think the other thing that they're doing, which is really important, is actually making sure that there's a more diverse and culturally concordant workforce and team that is supporting the mother, whether it's community health workers, doulas, nurses, social workers, you know, physicians. I think we also need to invest in that, and that's the kind of difference that we're going to see, you know, from within the system. Lastly, I would say, you know, it's not just, you know, I think, again, as Lola said, the personal, you know, the people and the work that you have to do on the people. It's the work you also have to do on the processes and policies. And many of, again, our collaborators are actually working within institutions to develop new policies and processes that, again, have been informed by community voices, and that are working to dismantle, you know, some of these legacy effects of systemic and structural racism.
Mm-hmm. Thanks, Marianne. That was a very comprehensive, and you touched on so many things. Maybe just talking about actually the diverse workforce and policy and practices. Lola, you work as we know, in a hospital in a clinical setting. What have you observed, you know, to be that works or not work when it comes to the workforce, when it comes to addressing implicit bias in terms of patient interaction?
Yeah, that's a great question. I think that There's no doubt about it. All efforts to really increase the workforce diversity is good efforts. I mean, the patients will tell you, in my experience, in particular, I'll tell you that there are certainly times when patients will reveal certain things to me because of the simple fact we are of the same cultural background, and there is a certain sense of belonging that may be there, or something that they feel more comfortable to be able to share certain aspects of their care that they may not feel comfortable sharing with other people. And unfortunately, that's the way that it is. And there's no doubt about it. In the media, there's a narrative there that says that, the doctors won't listen to you, or, nurses are not listening to you. Certainly that happens to a lot of people in the healthcare setting, whereas they feel that if there is a concordance by race or by culture or what have you, they feel that there is that line of communication is more open, and they feel more able to share certain things. And these are comments and complaints or issues that the patient is experiencing that could certainly save their life. So, really withholding that information or feeling like they can't share that is certainly a situation that can be detrimental to their own health. Now, it doesn't mean to say, it would be naive to say that there should be one Black doctor for every Black patient. That is unrealistic. So I think that all of us as the workforce, in general in the healthcare setting, have a duty to really be able to open up those lines of communications with our patients. I say parents because I'm a pediatrician, with our patients. I think that once we, regardless of your background, are comfortable enough and you're at a place where you're able to have an open dialogue with your patients, at that point, color doesn't matter, ethnicity doesn't matter. I think people want a healthcare provider that will listen to them. Right now, it's easy to say it's because we're not of the same background, but that I know for a fact is not the case. I think a majority of patients, as long as their clinician is there and willing to open up the lines of communication, and that physician is committed to taking care of their patient, then I think a lot of these issues that we're seeing will not exist. So while certainly I agree that the diversity in the workforce is necessary, I think that there are other issues and areas also that can help to help support and open up the lines of communication with our parents and patients.
We got that. Yeah, I mean, listening is so important. I wish all doctors listen to their patients.
That's right.
It's such an important skill. And just to, you talked a lot about all of this actually starts even before people show up in the clinic, right? It starts in their home, in the city or county where they live, in their history, kind of the trajectory that they've taken. If you had unlimited resources as a doctor, what would you do to address some of those outside of clinic factors?
Yeah, there are a number of things I wish I could do. Like I said, the care that I provide in the hospital is but a small piece of the pie. I think that the effects of structural racism are so deeply entrenched and entwined in our society that it would, again, be naive of me to think that I know the solutions to how to unwind this. This is centuries, decades of policies, practices, and customs since the time of slavery that are now affecting us to this day. But I wish if I had unlimited resources, I would go beyond my role as a clinician and really figure out how, from a policy perspective, for example, to tackle every one of those social determinants of health. I mean, housing, education, all of these areas, we know that there are systemic issues, systemic racism, factors that are influencing the overall health of our society. So I think one by one, tackling all of these areas outside the four walls of the hospital that we know for a fact influence our overall health and our well-being of all people, that's where I wish I could put the resources. There's no doubt about it. Certainly there's work to do within hospitals. We know that the quality of a hospital is important. We know that Black preterm babies are more likely to be born in hospitals of lower quality. So we need to elevate that. All hospitals really need to be at a certain level of quality so that everyone is receiving the same amount of care. As clinicians, we have work to do with our own biases, and that influences the care that we provide. So certainly there's work to do within hospital settings, but undoubtedly, if I had all of the resources and money in the world, it will be developing these cross-sector partnerships similar to this dialogue that we're having here to really develop interventions to one by one hit all of the systems in place that are perpetuating the racist sort of effects that are affecting our social determinants of health.
Mm-hmm. Thank you. Yeah, and to one of those outside of the hospital, solutions. Just going back to the transport point, Michele, as you mentioned, this program, the Uber for Moms, the Rides for Moms program, is serving mostly women from communities of color. What do you think? I mean, it's so interesting that a private company is doing this, right? What do you think it would take to actually, shift the policy so that the government is providing affordable, easy to, get transportation services for moms to get to their appointments?
Yeah, no, that's a great question, Sema. And before I get to that, to answer that, I do want to raise just one other thing in terms of addressing systemic racism. It's not just also in our systems, it's also where our health centers are located. I've lived in the District of Columbia for nearly 10 years, but I've been in this region my entire life. And with 700,000 people who live in this city, there is not a hospital that provides care for pregnant people east of North Capitol Street. And so you have tens of thousands of mothers, if not more than that, who do not have access. They have to drive literally across the city or outside of the city in order to give birth. And so taking a look at like how systemic racism has even affected where we are placing our healthcare systems, I think is something we want to think about. But to your question about how to get, how to inspire government, I will say, and getting them involved, we are at an interesting point in time right now where I think there's constant conversations about services that are provided and funding that is necessary, and understandably so. But I think this is where it's a time for government to look to private partners like rideshare companies such as Uber to be able to sort of tackle some of the gaps that we know they're not able to fill. So, for example, I believe that like pregnant people who are on Medicaid are currently eligible for free transportation to prenatal appointments through non-emergency medical transit. But going back to the point I raised earlier, with 68% of our participants in this program saying that they don't have access to reliable transit, there's obviously a disconnect that is there. So even though some of these women may have access to it, may be eligible for it, they don't have access to that transportation. And so taking a hard look at what government is actually doing in terms of providing transportation and how we can help fill in those gaps, especially knowing that we do have the resources and innovation to be helpful in that space. And that's part of the reason why I'm excited about this partnership, because we're going to take a look at just how we were able, just with 1,000 people, to maybe be able to address, concerning numbers in the city when it comes to maternal health. And so being able to take that data, go to our city leaders and say, hey, look, we were able to do this with just 1,000 people. How else can we help you fill those gaps beyond? I think is important. And so recognizing that there are some constraints at times, whether it's financial or otherwise, but offering our services, I think, is the first thing to do. And I'm glad to work for a company that said, look, we have this platform. We don't just do food delivery and rideshare, that we can use our platform to help people has been great. And being able to go to our local leaders and say, look, this is how we can help you, I think is a good step.
Can I add something there as well? Because Michele, I think it's so important what you said about not just the private sector collaboration, but also the innovation. Because even if you look at the issue of transportation, and you mentioned where in some areas they may not actually be a public sector transport infrastructure. I remember when I was practicing, the only options were a Metro card. And I think that right now with the new innovations that we have, where there are multiple options, not just from the public sector, but from the private sector, and we have the kind of platforms that allow for data exchange in order to track outcomes. This really is an exciting time about how we break out of those, historical silos that said, the solutions are only in this lane. How do we get out of our lanes, and work across these sectors, to support women. So it's actually convenient for them, because they used to stand in 2-hour lines just to get that Metro card. And, that's the cost benefit analysis of that, at the end of the day, that doesn't, it does not work for them. So, I wanted to emphasize that point. And also, the question you asked, Sema, about, where would you, spend your money? And I think actually the quick, easy answer to that is like, look at the MBI index, and see what it's telling you about what's driving that gap. One state that is actually, I think, doing a lot better than others in this space is New Jersey. And thinking, again, based on the leadership, leadership of the First Lady there, really bringing different agencies and different sectors together to solve for the barriers and the drivers that they're seeing.
Mm-hmm, mm-hmm. Yeah, I mean, thank you, Michele and Marianne. I think the cross-sectoral engagement, collaboration, and the need for innovation, and Michele, you highlighted many areas in the US. Yes, women actually do not live near a hospital or live very far away from a hospital or a clinical setting. And I actually found it astonishing to know that more than half of all US counties do not even have a single OBGYN, which is just hard to believe, to be honest. So, Christy, I know that, talking about innovation, EMC has invested and works across community-based, culturally relevant models of care to be able to close this gap. So including midwifery and doula support. Love to hear a bit more about these programs, how they work, what gap they're closing, and about the importance and impact of these models.
Yeah, I think when we look for models of care which are addressing respectful care, providing quality care, midwives come to mind immediately, community-based doulas as well. There's a lot of evidence behind both kinds of providers that indicate better birth outcomes for moms and babies. And yet we have a shortage. There are only or less than 14,000 midwives practicing in the United States. And of those 14,000, I think there's only about 5 to 6% of whom are women of color, people of color. So there's a lot that can be done with regard to, I was thinking about the investment of just that pipeline of community-based models of care. I think there's so much to be still done there. Again, the models of care are so important because I think the midwifery model of care is one that any kind of provider can learn from. It does put the patient at the center. It does take into consideration the whole person. And then the doula tends to have more of an understanding of what the home life is like for a patient. What's the community like? What's going on in that mother's life? Is there housing security? Is there a partner? Is there, I don't think most people understand just how complicated it is to navigate our systems. Even if you are eligible, it is an unsurmountable task for a single mother without childcare and consistent work to navigate our system. So there's that. And then there's also the piece with regard to the midwives and doulas where we're not reimbursing them for providing such high quality care. And so we really need to address that problem as well.
And these models of midwifery and doula are actually quite prevalent in other parts of the world. Can you talk a bit about that? And Marianne, feel free to also jump in because I know both of you work globally.
Yeah, I mean, there's a huge call for more midwives everywhere. Last year was the year of the nurse and midwife. And yet there are countries, when we look at the whole world and we see which countries are doing better with regard to maternal mortality and morbidity, there are countries that typically have midwives integrated into the health system. In the UK, for example, a mother gets to choose OB-GYN or midwife. And typically, if you're a low risk pregnancy, you see a midwife in most Northern European countries. And only if you have a complication or you're high risk do you seek care from a surgeon. So it's sort of an upside down look at the way that it's worked historically. And yet, even with the data and the proof and the stories and the experiences of the patient or the families that are able to access this quality of care, we're still having a really difficult time ramping up and making the case for midwives. But we are committed to this, and we are helping to invest in the pipeline to grow it.
Great, thank you. Lola, I wanted to ask you about the postnatal care that mothers are getting. And so there's a movement away from a single visit postnatally to a more comprehensive model. Can you talk about the importance of this model? Actually, to be honest, I was even surprised that it's a single visit. So maybe if you can talk about this shift and what are the challenges of delivering this?
That's right. Yeah, certainly I can speak to it from the perspective of a pediatrician. You know, there's no doubt that high quality, comprehensive postnatal care is necessary if we're going to improve maternal and infant health in our country. Pediatricians like myself have known that our patient is not only the child, but the parents as well, because there are so many things that our parents bring into the clinic that we are there and we need to face. You know, I think that as a profession, there's certainly a true push right now to materialize this and really develop clear resources and care models to provide a more holistic approach to caring for the entire family. And this is the case even in the neonatal ICU where I work. For example, we can look at postpartum depression. You know, this is an important, a very important aspect of the postnatal period that needs to be addressed for women. It is, we know, the most common complication of pregnancy. It has both short-term and potentially long-term effects on the mother and the child as well. And we found that parents of patients in our NICU are at a greater risk of postpartum depression. They experience perinatal mood and anxiety disorders at a higher rate than parents of healthy newborns. And while my job is a neonatologist, my job is to care for the infant's health, there's no doubt that we cannot continue to ignore what the mother is experiencing, what the father is experiencing as well. As I mentioned, the work that we do is but a small piece, but the environment that that child is going to go to, including the psychosocial environment, really has lasting effects. So one of the initiatives that we've done at Children's National is to really incorporate postnatal depression screening to all parents of newborns throughout our hospital. This is in our NICU, it's in our pediatric emergency department, it's in the cardiac ICU. Whenever there is a parent interfacing with us at Children's National, we want to make sure that that parent is being screened for postnatal depression. And you know, the outcomes of this initiative in the past few years really has been telling. You know, it's not uncommon for mothers or fathers to tell us, you know, this is the first time someone has asked me, how am I feeling? You know, oftentimes for the babies that I care for, the patients are so sick, it's not uncommon for the mothers to even miss their OB-GYN postnatal visit because they're so focused on the child. And typically the standard is that the OB-GYN would screen for depression at that 6-week visit. But our babies have been sick for the past 6 weeks and have been in creating such a traumatic and stressful experience for the parents that they really need to have their mental health addressed early on. So this, I think, is an example of how we can reimagine high quality, comprehensive postnatal care. This is how it should look like. You know, really our patient is the baby, but also the entire family. And I think that there's certainly a push for this in the field of pediatrics as well as in OB-GYN as well. There's no doubt about it. There are challenges mainly being resources, right? Where's the workforce that's needed for this? We can't just screen parents, for example, in the children's hospital and not have a plan to intervene. We need more mental health workers. We need more psychologists. We need to bring them into the hospital setting as well. And we know that that workforce is limited. So resources in terms of workforce, reimbursement to the clinicians and the providers for providing these services. This is something that really needs to be elevated, and reimbursement needs to improve so that this sort of service can be sustainable, accessible to all parents, and to really to follow through for the care that we need to provide for our families in general.
Thanks, Lola. And just to add, actually, in the MVI, we do capture access to psychosocial services. So that's an important indicator, and we need to pay more attention to that for women, as you mentioned. Great. So we are now going to move on to our audience Q&A. Very exciting, and we have a lot of questions. So we're going to try to move through these through as much as possible. So I'll start with Kate from the audience. Kate asks, there's so much unknown about how maternal health, preconception through pregnancy and during lactation and weaning impacts infant birth and growth outcomes, as well as pregnancy outcomes for moms, let alone how systemic racism influences these critical periods from and biological processes. The question is, what is needed to significantly increase the critical research and data we need to understand the underlying biology and vulnerabilities impacting outcomes in the maternal health context across public sector, private sector, industry, and academia? Lola, do you want to take it?
I have a thought. I think this is a difficult question, and I think that everyone that is involved in this area of research is really working hard to figure out how to tease it out. I think one of the issues that is a challenge is, I think, in general, studies consistently, for example, defining race in a way that's consistent. If anyone has taken the census, if you answered the questions for race, there's like multiple options, because we need to get granular to figure out how we're defining race. Most of the studies, Black is all encompassing. African immigrants, Caribbean immigrants, for example, and we know that the health outcomes are different. Dr. Jimmy Collins in Chicago did a pioneer in this work when it comes to prematurity and looking at infant health. And, he did a study looking at the health outcomes of mothers of African descent, like they were immigrants in the United States. This was their first time here in the country. Their health outcomes, maternal health outcomes, are similar to that of white women. He then followed their children, the children of these immigrants. So now these are first generation Americans, and looked at their health outcomes. Their health outcomes are now that of what we typically say of Black mothers, meaning they have much worse outcomes. How do you explain that? How do you explain that? As someone immigrating to the United States from America, immigrating to the United States from Africa or the Caribbean, you have, better health outcomes. And then just within one generation, their children's health outcome is now poor in that of Black mothers, this all-encompassing definition. So I think there's a lot to learn just in that, just how we're defining things in our research. It needs to be consistent. And this is something that I think will be a challenge, but if there, are leaders in this area, similar to Dr. Collins, for us having guidance from the government also, when there are grants that are being given for studies, I think having a clear definition for how we will define race or define ethnicity and allow patients to define it for themselves. I think that will go a long way, and it's an important first step for us to even tease out the data and understand the data clearly.
Mm-hmm.
Yeah, I'd like to, I'm so glad this question was asked, because, as Lola started to share, we really need to be careful about this type of questioning, because it's very easy to start to conflate race and racism. And we should not be, I think, and I'm learning this from other birth equity champions like Dr. Joy Corey, that it's racism, not race, that is actually the driver of these poor maternal outcomes that we see. And so I think that's the first point I wanted to make. And then I think, so when you're talking about biological research, those it's very easy to go down that slippery slope. I think the other thing I'd like to say, and this relates to your previous question about where should we be spending the money and the resources, is, currently about 88%, of the resources are going into supporting, whether it's research or clinical care in the healthcare sector, even though we know that 80% of health outcomes are actually driven by the social determinants of health. So I do think that that's where we need to be focusing the bulk of our resources. I also think that we already know what to do, and so for the most part, and so we actually just need to put our money, where we know the results are, and work to actually close, that knowledge due gap. And I think when we actually are able to provide, high quality services and address the social determinants of health barriers, for all women, and we close that gap, then I think, we can start to invest in, the additional research, that we may need to. And just to bring it back to, the Merck for Mothers experience, I do believe that when the initiative started, and, we invested in the data, we invested in improving quality of care, and I think we assumed that, a rising tide will lift all boats, but that didn't happen. And so, we stepped back and said, okay, what do we actually need to invest in order to close the disparity gap, and recognize that we needed to put issues of birth equity front and center. That needed to be our primary goal. And we saw that it actually changed not just what we funded, but how we funded and our processes.
Thank you, Lola and Marianne. Moving on to the next question. Sohaya from the audience asks, how to encourage women to speak up and report their issues? She says, I think there's a significant fraction of women who are not aware of their rights and what they are really going through. Basically, they find it hard to distinguish a challenge that she should not mask and their role as a mother who loves her family. And relatedly, Sarah asks, are there mechanisms for parents who experience racial bias to raise their concerns within the hospital settings they've delivered their babies in? And to what extent are those facilities acknowledging this and taking the necessary action? Maybe Christy, I'll go over to you about mothers' voices, and then Lola, if you want to take on kind of the mechanisms in the hospital system.
Yeah, I think on that front, I think on the one part, we all need some guidance and some training around self-advocacy, right, in our medical institutions and facilities. And that's, I think, one of the reasons why doulas are such a wonderful solution, because essentially a doula is a patient advocate, right? They are there to help advocate on behalf of the mom or birthing person as events sort of shift and change. If you're not able to voice for yourself, to have that other voice in the room to advocate on your behalf is incredibly important. And this can be taught across families and in communities as well. It just happens to be that doulas do that. That's their main role. I think in some instances, there's one really amazing app I have to give a shout out to, which is called the Earth app, and it's basically birth without bias, and it was created and launched earlier this year by Kimberly Seals Allers, and essentially it's like a Yelp for patients who are of color to be able to report back what their experience is in any one facility. I think it's so needed because there isn't always that channel for experience to come back to the site itself or to the providers that are providing the care. And so this is one way that I think has a lot of potential, and everyone can have access to it, which I think is also a really important aspect of this.
Yeah, thank you for that shout out. I actually saw that a few weeks ago. It is really interesting. Lola, over to you about
Sure.
what happens in the facility.
Yeah, most hospitals, I can certainly speak for the hospitals in which I've worked, and I've worked in New York City, I'm now here in DC. Most hospitals have a patient advocate. This is their role. And I think, and this is someone that you can ask to speak up Generally, they're accessible by email, by phone. Some hospitals, this person is an ombudsman. There's different titles that they use for them, but essentially their role is that of a patient advocate. You know, in the NICU setting, for example, our social workers essentially are that role to be the advocate for the families as well. If they feel like the lines of communication have broken down with the provider team and the family, our social workers are there to really help to facilitate. But even outside of the clinical setting that you're in, there's often someone designated within the hospital system that is their job, to be an advocate for the patient and to really to speak to the medical team or whomever that needs to be addressed. I will tell you that at Children's National, within our diversity and equity program, we have a section that is focused just on the patient, family, and community engagement. So there, you know, we have a number of initiatives to make sure that every patient feels like and family feels like they can speak up and advocate for themselves. If, for example, if we have an incident of bias that's reported within our hospital, it's thoroughly investigated by our Chief Diversity Officer, and follow-up is provided to the family and to the rest of the hospital. So, you know, I think every hospital has their own system, and certainly hospitals that take this work very seriously are putting systems in place so that families have the opportunity to share any concern that comes up.
That's wonderful to hear. Molly, Michele, I'm gonna have this question from Molly to you, because I think you have a really interesting journey. So Molly asks, what would you suggest to someone interested in being part of these solutions in maternal health? What are some of the ways to get involved?
That's a great question, Molly. So prior to coming to Uber, I actually worked in local government. And while I was a staffer at the DC Council, a very dear friend of mine was pregnant with her first child. And she called me, she was alone. She called me and she said, you know, I'm having difficulty seeing, and, you know, I don't feel sick, but I should probably go to the hospital. And so I drove across the city and took her to the hospital. Unfortunately, she did not live near one. So we drove all the way to Northern Virginia for her to give birth. Or actually, we drove to Northern Virginia just to see what was wrong. I am not a mother myself, and this was her first child. So it's like the blind leading the blind a little bit here. And we get to the hospital, and her blood pressure is so high that she had to have an emergency C-section because she had preeclampsia. And it became really a personal passion of mine because I almost lost a really dear friend. And so what I would suggest to you, Molly, one of the things that I did before I came to Uber was I used to volunteer on campaigns. I used to get very involved in terms of locally elected officials who I thought pushed for the things that I really and truly cared about. Councilmember Christina Henderson is one of those individuals. She ran on her concern for maternal health here in the city. She lived in a good community, is highly educated, and yet she had difficulty getting into a hospital just to give birth. And that tells you that it does not affect just low-income mothers. It literally affects everyone. And so I volunteered on her campaign. I've been a supporter of hers, and I've been a supporter of other elected officials who I think really have pushed for these types of programs that will help women who are vulnerable and pregnant people who are vulnerable in the city. And so I certainly encourage you to look at who your leaders are and to push them on that. As someone who worked as a staffer, I will tell you that writing letters actually does matter. Sending emails, those things actually do matter. And so it started there. There are also wonderful organizations that I think you can also volunteer with as well. Mary Center and Community of Hope are two organizations that we're partnering with that I think are great. I think some other folks have listed in the chat some other organizations. And so it can just start with your own personal story and then advocating from there.
Thanks, Michele. So moving on to the next question. And I think this comes to also some of the quality issues that we talked about. Marian asks, has data been collected on maternal health by hospitals in the US? How much of increased mortality is attributable to babies being delivered at lower quality, under-resourced hospitals? Marianne, it sounds like you want to jump in here.
Yeah, I can take that. So, one of the goals that Merck for Mothers has is not just that, every death, gets counted and investigated, but every hospital is instituting quality of care standards for maternal health and reporting on those. Some of the work that we've funded over the years, has helped to scale that, both, whether it's been California or New York State or working with national coalitions. But what I will say is that it's not comprehensive, across the country. And because of that variability, that is where people fall through the cracks. To the second part of your question around how much of the outcomes can be attributable to the quality that we see in hospitals. Actually, one of renowned maternal health researcher, Dr. Elizabeth Howell, actually did a study in New York City looking at severe maternal morbidity and looking at the whether the location of birth, how much that affected or could explain the gap. And she found that only about 50% of the racial disparity gap in maternal health outcomes could be attributable to the facility, of birth. And so that's 50% that's happening, that's being caused by something outside of the facility, so community factors, environmental factors that we can understand more about through the, maternal vulnerability index, or because women are receiving different care in that facility. And that, more than likely is probably due to the effects of systemic racism. And so, we need to tackle all of these issues if we are to close the gap. To the question about, I can't remember, I think it was Miriam who asked the question about, how can she get involved, or Molly, how can she get involved? I think that there are so many ways to get involved because there's not just one cause of maternal mortality. It's multifactorial, it's multisectoral. So whatever you do, whatever is your passion, there's a way, I think, that you'll be able to link it to improving health outcomes for mothers.
Great. We are a few minutes left almost to wrap up, and there is one question I think asked by Aisha. Aisha asks, so there's as we know, there are many factors, structural factors, environmental factors that we know are important. If you had the opportunity to invest in one, which one would be the most important one that you would put your money behind right now? Of course, we know it's more than one, but if you were to choose one, I would like to hear from each of the panelists, please. Marianne, feel free to start.
Putting me on the spot, I think, actually it will be, for me, it will be investing in people, particularly the people who are most affected by this issue. So Black women, women of color, Native American, Indian women, and investing in them from the get-go, in their education, in their training. And because of that, then you have a voice and you can be at the table when solutions are being decided upon. So I think the answer to me is investing in the people that are most impacted by this issue.
Thank you, Marianne. And I think Lola is next.
Well, I just wanted to piggyback on that perfect answer. I wanted to say, I think that it is so hard and I think impossible to tease out and say, it's the educational system solely or economics solely. I think it is so intertwined and so comprehensive. Everything really plays on each other. So I think investing in the people makes a lot of sense and would be ideal. I think in terms of the numbers here in our country, There's no doubt about it that it's disparate care, and and there is a disparity there. So kind of focusing on those most affected really makes the most sense.
I just want to just push back a little bit on that, in the sense that one of the things we know that despite women's education and economic outcome, women of color still, fare worse, right, than white women. So I just want to elaborate a bit more. Investing in the women so that their voices are heard is critical. Do you see that playing out in different ways and addressing some of the other factors? I'm just curious how that would play out.
The way that I see that personally, this is just me speaking here, I think that there's no doubt, that, I've seen the studies, they've looked at educated Black women, for example, had bad outcomes also. But I think if you were to compare the outcomes of a Black person who has higher education versus one that doesn't, there's going to be a difference there. So I think any personal empowerment that can happen, be it educational, financial, and anything, will be a step towards progress. I don't know the answers yet to resources that can take away someone else's implicit bias, someone else's ideas of racism, and how I don't know yet how to change how other people make decisions. Certainly, there's been efforts to increase awareness, implicit bias training, as Marianne mentioned. They're there. The jury is still out whether that has made a difference yet in outcomes and how clinicians perform. But I think that there's nothing like a person empowered to be able to feel like they can advocate for themselves. It doesn't answer at all. There's no doubt about it. I know that this doesn't solve the problem, but it certainly doesn't hurt either.
And just to clarify, I was not advocating not to invest in women, but
yes,
I just want
I know.
to juxtapose those.
Just to add one thing, Sema, this is the tragedy of the situation. So all of you I know are aware of Dr. Shalon Irving. She's someone who you could make the argument that whether education, professional knowledge, income didn't make a difference for her life. But during her life, she made a difference for a lot of people. And so I think that, that is, the investment, in people, unfortunately, the tragedy, may not make a difference for your life, but can make a difference for others.
Yeah. Thank you for that. Michele, I was curious if you had any thoughts in terms of where would you put your money, again, knowing that there's many things that need to happen, but first.
Sure. I certainly agree with my fellow panelists, and I would say, thinking back to my government days, if I could have a dedicated source of funds for something around this, I think it would be something that Christy spoke about earlier, and which is having more access to doulas and midwives. I do think this is all anecdotal. I know we're having a conversation about data, but this is just anecdotal from my own personal experience and conversations with some of my friends. They don't always necessarily feel comfortable. There's a network of Black women that I know in the city that they talk amongst each other about who to go to when it comes to OBGYN services and those sort of things, because there's not a level of trust. And so expanding the options and alternatives for mothers, particularly mothers of color, when it comes to trusting someone to help them through this, is something I would love to see.
Right, and thank you, Michele. And Christy, last word to you, not least.
Yes, definitely the investment in the folks at the community level, but also I would say across the whole maternity care ecosystem. I think we're really focused on this team-based approach. I think it's so essential when you're bringing life into the world that you have a team around you, supporting you in that way. And again, centering the mother and the birthing person. And so, you really need our nurses and our midwives and our anesthesiologists and our pediatricians and our doctors all to be working together as a team. That's why my life was saved when I gave birth. And that's what I wish for every mother.
Great, thank you so much. Well, unfortunately, we're at the end of our time. It just went by so quickly. I just wanted to say a heartfelt thank you to all our panelists. This was such an amazing conversation. I learned so much. And based on the questions that we've had, I know that this has been really very, very useful for our attendees as well. Thank you for sharing your time, your insights. To our audience, on our closing slide, you will see more information on the Maternal Vulnerability Index and how you can stay engaged with our work. The MVI, just as a reminder, is an open source tool and available at no cost. We encourage you to visit the site, to explore it, to send us feedback, questions. Please, spend as much time as you'd like. We would love to hear from you. And again, thank you all so much and have a wonderful day.